Okay, so now we're going to talk about the care of patients with GI alterations, part 6. So we're going to talk about cirrhosis. The liver is the largest, one of the most vital organs. It has over 400 functions and affects every system in the body. When the liver is impaired, digestion, nutrition, and metabolism are affected. Causes in the United States, the most common cause of cirrhosis is Hep C. Worldwide, the most common cause is Hep B and D. Cirrhosis from alcoholism is reversible to some degree. Illegal drugs like cocaine also tear up your liver. Biliary cirrhosis is caused from gallbladder disease. So let's talk a little bit about the pathophysiology. It is a widespread fibrotic bands of connective tissue that change the liver's normal makeup. Inflammation is caused by toxins or disease and results in the destruction of hepatocytes. Tissues become nodular. This causes blockages in bile ducts and impairs blood flow through the liver. Over time, the liver shrinks in size, resulting in decreased liver function, and the damaged liver kicks out increased liver enzymes to compensate. There is degeneration and destruction of hepatocytes. Tissue becomes nodular, which can block bile ducts and normal blood flow. Causes can be alcoholic cirrhosis, post-necrotic cirrhosis, that's viral or drugs, biliary cirrhosis, and cardiac cirrhosis. It can be compensated or decompensated. So basically it's going to affect the digestive, the circulatory, the biliary, and it can be compensated or decompensated. So I'm going to start talking about portal hypertension. There's a persistent increase in pressure within the portal vein. The blood meets resistance to flow and seeks collateral venous channels around the high pressure. This results in splenomegaly, ascites, esophageal varices, prominent abdominal veins, and hemorrhoids. Remember we talked about ascites earlier, about being a collection of free fluid within the peritoneal cavity that's caused by an increased hydrostatic pressure from portal hypertension. It reduces the plasma protein in the blood, and additionally the liver already has limited ability to produce albumin. This results in a fluid shift from the vascular system into the abdomen, called third spacing. Complications will depend on how the damaged liver is and to what degree of compensation is occurring. In the portal hypertension, persistent increase in pressure is within the portal vein is greater than 5. It usually occurs because of blockage, so the pressure rises and eventually the blood flows around the obstruction through collateral vessels. Blood backflows into the spleen, causing splenomegaly. Then vessels in the esophagus, abdomen, and rectum become dilated, causing hemorrhoids, esophageal varices, and ascites. Ascites and esophageal varices results from the portal hypotension. Ascites is the collection of the free fluid within the peritoneal cavity. Varices is the blood backs up from the liver to the esophagus, and the fragile thin-walled esophageal veins become distended from increased pressure. They have the potential to bleed. This is life-threatening. It is a medical emergency. There can be severe blood loss and may either have hematemesis or melena. Coagulation defects include the production of bile in the liver is decreased. This prevents absorption of fat-soluble vitamin K. Vitamin K has to be present to make other clotting factors. Therefore, the patient is susceptible to bleeding and easy bruising. It also causes splenomegaly. The enlarged spleen destroys platelets, causing thrombocytopenia. Thrombocytopenia is often the first clinical sign that a patient has liver dysfunction. Then we're going to talk about jaundice. That is the #1 cause. Hepatocellular disease. It's the damaged liver cells that cannot effectively excrete bilirubin. Or the #2, intrahepatic obstruction. All the extra bilirubin is floating around, clogs up the pipes, and causes obstructions. Let's talk about PSC with hepatic coma. This is a progressive disorder caused by toxic substance absorbed by the intestine that are not broken down or detoxified and leads to metabolic abnormalities such as elevated serum, ammonia, and GABA. This affects the functions of the brain. Clinical manifestations include sleep disturbance, mood disturbance, MSC, speech problems. It progresses to impaired thinking and neuromuscular problems. Factors that lead to PSC are high protein diet, infections, hypovolemia, hypokalemia, constipation, and GI bleeding, and drugs. Then we have hepatorenal syndrome. This indicates a poor prognosis. Clinical manifestations are sudden decrease in urinary flow, elevated blood urea nitrogen and creatinine levels, decreased urine sodium excretion, increased urine osmolarity, and it often occurs after clinical deterioration from GI bleeding or onset of PSC. Then we have spontaneous bacterial peritonitis. This is most acceptable in advanced liver disease. It may be the result of low concentrations of proteins. They're supposed to protect against bacteria. Bowel bacteria reaches acidic fluid after migrating through the bowel wall and lymphatics. Clinical manifestations include fever, chills, abdominal pain, and tenderness. Diagnosis by sample of acidic fluid by paracentesis. So diagnostically, we're going to look for elevations in AST, ALT, LDHs, decrease in the fecal urobilinogen, serum total protein, serum albumin. They'll have a prolonged PT lab. You want to see page 1299, table 61-4 in your textbook. They may do an ultrasound, an X-ray, an MRI, a biopsy, and an EGD. For collaborative care, they're going to need vitamins because they can't store them. A paracentesis is done usually in radiology under ultrasound guidance to drain off some of the ascites. They test a fluid for infection, always looking for peritonitis. They may have hepatopulmonary syndrome. They'll have dyspnea from increased abdominal pressure. Do the paracentesis for relief. Not you, the doctor will. Reduce bacterial breakdown via diet and drugs. Have them avoid opioids, sedatives, and barbiturates. You do want to use lactulose, which promotes excretion of ammonia in the stool. Or use non-absorbable antibiotics such as neomycin, flagyl. They want to avoid NSAIDs. You want to assess for changes in level of consciousness, asterixis, vector hepaticus. These suggest worsening encephalopathy. Recall, ammonia is a byproduct of gut bacteria. Damaged liver cannot convert the ammonia to less toxic form. As a result, the ammonia is carried to the brain where it affects cerebral function. If patients have GI bleeding, then even more ammonia is released as the gut bacteria metabolizes red blood cells. Lactulose is a laxative given with the idea of promoting elimination so that will decrease the bacterial and ammonia levels. Okay, now we're going to talk about hepatitis. This is a widespread inflammation of liver cells, acute versus chronic. Viral hepatitis is caused from an infection caused by one of its 5 major categories, A, B, C, D, or E. There is toxic and drug-induced hepatitis. It can occur as a secondary infection. There is Hep A, B, C confirmed by elevated liver enzymes. You will check the ALT and AST levels may rise. HAV antibodies would be found in the blood as well as antigen antibodies for HBV. People who have been vaccinated will also have a positive HBsAg because they have immunity. Liver biopsy may be used to confirm diagnosis. For all viruses of the liver, the plan is to rest the liver, promote cellular regeneration, and prevent complications. For patients with Hep B and C, antiviral and immunomodulating drugs are used. Additionally, things such as PEG Intron is given in Hep B patients to increase immunity by reducing replication. Hep C, there is a combination of subcutaneous pegylated interferon alpha once a week and oral ribavirin daily. Genotype does not make a difference. There is a widespread inflammation of liver cells. Viral is the most common type. Viral hepatitis is caused from an infection caused by one of its 5 major categories. Non-A through E hepatitis cases are usually toxic and drug-induced hepatitis. After exposure, the liver becomes enlarged, congested with inflammatory cells, lymphocytes, and fluid, resulting in right upper quadrant pain. The lobular pattern is distorted with increased pressure. Edema in bile channels causes the jaundice. There are 5 major types, vary by mode of transmission, manner of onset, and incubation periods. Must be reported to the public health department. That in turn notifies CDC. So Hep A, it's a hardy virus and survives on human hands, spread by oral fecal route. Similar to GI illness, with recovery being uneventful, but to some it can be life-threatening. 2 vaccines are available. Hep B spread, unprotected sexual intercourse, sharing needles, needle sticks or sharps, blood transfusion, hemodialysis, and maternal fetal route. Clinical manifestations could be anorexia, nausea, vomiting, fever, fatigue, right upper quadrant pain, dark urine with light stool, joint pain, jaundice. Some people can become carriers. There are 2 vaccines that are available and recommended for healthcare workers, police, and firefighters that are exposed to blood or body fluids in the workplace. Hep C. Transmission is blood to blood. The virus does not clear and have chronic infection. Most are asymptomatic. Leading indication for liver transplantation in the United States, and new liver may become infected. Most common type and expected to grow, and by the way, there is no vaccine. Hep D occurs only with Hep B. Spread by parenteral routes. Sexual contact will put you at risk. Incubation is 14 to 56 days. Hep E, caused by contaminated water by fecal matter, often occurs after flooding. It is self-limiting, limited to international travels in the United States so far. They may have abdominal pain, changes in skin or sclera, arthralgia, myalgia, diarrhea, constipation, changes in urine color, fever, lethargy, malaise, nausea and vomiting, and pruritus. ALT and AST levels may rise, bilirubin will increase, HAV antibodies will be found in the blood as well as antibodies for HBV. People who have been vaccinated will also have a positive HBsAg because they have immunity. Liver biopsy may be used to confirm diagnosis. Antiviral and immunomodulating drugs are used. For Hep C, there is a sub-Q pegylated interferon alpha once a week and oral ribavirin daily. Talked about that earlier. So the length of treatment will depend on genotype. Now we're going to talk about a fatty liver, steatosis. It's caused by accumulation of fats in and around the hepatic cells. Causes include diabetes mellitus, obesity, and elevated lipid profile. It's often asymptomatic. Diagnostically, we'll look through an MRI, an ultrasound, or nuclear medicine confirmation. When you look at hepatic abscess, they have a high mortality rate. It is a necrotic cavity that is filled with infective agents. The patient is very ill. It's generally not diagnosed until an autopsy has been performed. Clinical manifestations can include right upper quadrant pain, tender liver, weakness, malaise, anorexia, weight loss, pleural pain, shoulder pain, nausea, vomiting, fevers, chills, and dyspnea. It's diagnosed by a CT or ultrasound and generally drained with CT or ultrasound guidance. They may also have antibiotic therapy. Let's talk a little bit about liver trauma. Often injury is caused by steering wheels in vehicular accidents. There can be a blood loss that can be massive because the liver obtains about 1/3 of the cardiac output. It is diagnosed through an ultrasound or CT to confirm, which is followed by a laparoscopy. You want to anticipate that these patients are going to need a blood and blood products. Liver cancer can be caused from chronic infection with HBV and HCV. It may lead to cirrhosis, which is a risk factor for developing liver cancer. We have alcoholic liver disease that increases the risk for cancer. Some others are hemochromatosis, smoking anabolic steroids, androgens and estrogens. There's exceptionally no effective treatment at this time. When a patient needs a liver transplant, it's usually due to the major cause of HCV. There's a primary tumor and is another cause. United Network of Organ Sharing is a company that you can actually, or organization you can go through to get on a list for a liver transplant. The highest level of acuity receives highest priority. Complications can include graft rejection and infection. The key thing to remember is your pre-op and your post-op procedures for any type of surgery. This concludes part 6 of GI alterations. If you have any questions related to this content, please contact the instructor.